Hello everyone, I am Dr. Pooja Vyas. First of all, I would like to thank Dr. Kamal Sharma sir and his team for giving me this opportunity. Topic given to me is echocardiographic quantification of aortic stenosis. So scenario given is 80-year-old female and being treated with nitrates for angina and whose previous angiogram 10 years back was suggestive of 30% lesion in LAD, and now she presented with dyspnea class 2 and angina class 3, and on auscultation there was an ejection systolic murmur with soft S1 and S2, and the junior resident is confused as his outside echo report is showing moderate aortic stenosis with fair LV function. So how would I quantify the severity of aortic stenosis using echocardiography? So first of all, let us go through the stages of valvular aortic stenosis. Stage A includes patients who are at risk of aortic stenosis with aortic Vmax of less than 2 meter per second. Stage B includes the patients with progressive aortic stenosis, which includes mild aortic stenosis and moderate aortic stenosis. For mild aortic stenosis, Vmax should be between 2 to 2.9 meter per second, and the mean pressure gradient should be less than 20 millimeter of mercury. And for moderate aortic stenosis, aortic Vmax should be between 3 to 3.9 meter per second, or mean pressure gradient should be between 20 to 39 millimeter of mercury. Now stage C includes asymptomatic severe aortic stenosis patient. Severe aortic stenosis is considered when we get aortic Vmax of more than or equal to 4 meter per second, or mean pressure gradient of more than or equal to 40 millimeter of mercury. And at that time, aortic valve area typically is less than or equal to 1 centimeter square. And very severe aortic stenosis is when aortic Vmax we get is more than 5 meter per second, or mean pressure gradient is more than 60 millimeter of mercury. Now, stage C2 are the patients who are asymptomatic severe aortic stenosis patients with LV dysfunction, while stage D includes the symptomatic patients with severe aortic stenosis. So the severe aortic stenosis here can be of 3 types. D1 includes those patients with high gradient, high flow aortic stenosis. And D2 includes those symptomatic patients with severe low flow, low gradient aortic stenosis with reduced ejection fraction. And D3 are the patients with paradoxical low flow severe aortic stenosis, which we will discuss later on. The goals of echocardiographic evaluation for aortic stenosis are to establish the diagnosis of aortic stenosis, to quantify the severity of aortic stenosis, and assess the left ventricular function. So Doppler assessment of the aortic stenosis usually starts with measuring the peak transvalvular velocity and then mean transvalvular gradient, and then comes the continuity equation to determine the aortic valve area. So echo window to be used to measure these velocities and gradients are apical 5-chamber view, suprasternal view, and the right parasternal view. Multiple views are to be used, and we should take care that Doppler beam should be aligned with the direction of the stenotic jet to get the perfect aortic velocities. Simplified Bernoulli equation is used to estimate the peak gradient, and this equation is a proven practical and non-invasive method for determining the pressure gradient across the aortic valve, and it correlates very well with the invasive pressures and gradients. So from the Doppler recording, by using the equation P equal to 4V square, here the velocity is taken in meter per second, and we can get the maximum pressure gradient across the stenotic valve. And to get the mean pressure gradient, another equation is there. So the mean pressure gradient equal to the maximum pressure gradient upon 1.45 plus 2 millimeter of mercury. Usually this is calculated by the software. It utilizes the data of the instantaneous velocities across the aortic valve, and it provides the value. So usually it is software generated. So here the color wave Doppler is put across the aortic wall in the five-chamber apical view, and what we get is the aortic velocity jet. And by tracing this aortic jet, we get that maximum velocity is 2.6 meter per second. So it suggests that it is mild aortic stenosis. And aortic stenosis should be quantified not only in one view, it should be quantified from the multiple views. See here in the figure 1, the aortic velocities were taken from the apical five-chamber view, and it showed the velocity of 3.9 meter per second, while the right parasternal view showed the velocity of 4.8 meter per second. So if the peak gradient would have been underestimated if the echocardiographer had concluded the examination with the apical views rather than moving to the right parasternal window where the higher velocity was recorded. Limitations of pressure gradient calculations. We should know that these valve gradients are dynamic, so it varies with heart rate, loading condition of the heart, blood pressure, and the inotropic state of the heart. So if there is malalignment of the jet and the ultrasound beam, it will lead to the underestimation of the pressure gradients. So any underestimation of the aortic velocity, it will result in the greater underestimation of the gradient, because the pressure gradient is equal to 4 by v square. And there is also one limitation, that due to the similarity in the location of the mitral regurgitant jet and the similarity of the location of the aortic stenosis jet and the direction of the jet, we may get confused with the MR jet. And in aortic regurgitation, usually the stroke volume is higher, so the flow across the valve during the systole will be higher, and it will lead to the overestimation of the aortic stenosis if there is coexistent aortic regurgitation. And in LV dysfunction, opposite will occur. Due to reduction in the stroke volume, there will be false underestimation of the pressure gradient. So it will lead to the underestimation of the aortic stenosis. Here see, due to the similarity in the location and the direction of the flow of the aortic stenosis and mitral regurgitation, there may be a confusion between AS and MR. So how to resolve that? See here, the vertical line, it provides a representative line in relation to the QRS complex. So there will be the gap between a vertical line and onset of the flow in aortic stenosis, while the mitral regurgitation, it starts with the isovolumetric contraction phase and it continues through the isovolumetric relaxation phase. So the duration will be more in case of mitral regurgitation. So complete evaluation of the quantification of the aortic stenosis includes aortic valve determination of aortic valve area using the continuity equation. And this continuity equation is based on the principle of conservation of mass. And the continuity equation states that the stroke volume proximal to the aortic valve must equal the stroke volume through the stenotic orifice. And because the stroke volume is the product of the cross-sectional area and the time velocity integral, the continuity equation can be arranged this way, that aortic valve area equal to cross-sectional area of the LVOT into a time velocity integral of the LVOT upon time velocity integral of the aortic stenosis. So to calculate the aortic valve area, we need three measurements. One is the cross-sectional area of the LVOT. Second is the time velocity integral of LVOT, and TVI of the aortic stenosis. To calculate the cross-sectional area, we need the cross-sectional area is calculated by this formula pi r square, and the diameter of the LVOT should be taken in the plex view, while the time velocity integral is to be taken in five-chamber apical view just proximal to the aortic wall by putting the pulse wave Doppler imaging. So it gives the time velocity integral of the LVOT. And by putting the continuous wave Doppler, we can get the aortic stenotic jet. And by this, by tracing this aortic stenosis jet, we can get the TBI of the aortic stenosis. So this is an example where the diameter of the LVOT is 2 centimeters. So radius is 1 centimeter. And by that, the cross-sectional area is 3.14 centimeters square. TBI of the LVOT is 11 centimeter. TBI of the aortic stenosis is 59 centimeter. And by putting these values in this formula, we'll get the aortic wall area of 0.6 centimeters square. And there is even a simplified version of this continuity equation where this TBI has been replaced with the maximum velocity across the LVOT and maximum velocity across the aortic wall. Considering that the flow duration across these two places is the same. So we can even calculate aortic wall area using this formula. And the continuity equation has two important advantages as compared to Bernoulli's equation. One is, if there is coexistent aortic regurgitation, Bernoulli's equation will overestimate the aortic stenosis, while continuity equation will not have that effect on it. And similarly, with LV dysfunction, there will be reduction in the stroke volume. And so the Bernoulli's equation will show the underestimation of the aortic stenosis, while that will not occur with the, this continuity equation. So there are some limitations of continuity equations too. So there is intra and inter-observer variability. So variability is noted around 3 to 4% while measuring aortic stenotic jet and LVOT velocity, and somewhat higher for measuring the LVOT diameter. It is around 5 to 8%. And when we have subaortic flow velocities abnormal, then stroke volume calculation at this site is not accurate. And other potential factors that can contribute to errors are image quality, annular calcification, non-circular annulus, and failure to measure the true diameter. So it is very important to measure the accurate LVOT diameter. It is because when we calculate the aortic wall area, the cross-sectional area is pi r square. So if there is even a small error, so it will be reflected highly in the final equation, because the it is in the equation the radius is squared. So the smaller error can lead to the big error finally. So we must take care while calculating the LVOT diameter. So according to ACC/AHA guidelines, we can say we will differentiate the aortic stenosis into mild, moderate, severe, and very severe category. So mild aortic stenosis is when aortic wall area is between 1.5 to 2 centimeters square and mean gradient is less than 20 millimeter of mercury and jet velocity is 2 to 2.9 meter per second. Moderate aortic stenosis is when the wall area is 1 to 1.5 centimeters square. Mean gradient is between 20 to 39 millimeter of mercury and jet velocity is between 3 to 3.9. We will say that aortic stenosis is severe when aortic wall area is less than 1 centimeter square and mean gradient is more than or equal to 40 millimeter of mercury and jet velocity is more than or equal to 4 meter per second. And very severe AS with wall area of less than 1 centimeter square, but the gradient here is even higher, more than 60 millimeter of mercury, and velocity is, peak velocity is more than or equal to 5 meter per second. So severe AS can be of 3 types. It can be either high flow, high gradient, normal LV with normal LV ejection fraction. It can be of low flow, low gradient with low LV ejection fraction, and low flow, low gradient with preserved ejection fraction, which is paradoxically low flow severe aortic stenosis. So here comes the role of dobutamine stress echo. So whenever there is LV dysfunction with severe aortic stenosis, there can be two diagnostic possibilities. Either it can be true anatomically severe aortic stenosis, or it can be pseudo-severe aortic stenosis. By saying pseudo-severe aortic stenosis, we mean to say that it is not severe, but it looks like severe aortic stenosis. So it is just mild to moderate aortic stenosis where the valve leaflets are not opening fully, and it looks like severe aortic stenosis because the stroke volume is low. So dobutamine increases the stroke volume. It allows the differentiation between these two possibilities just we discussed. And we assume that, the test assumes that if the leaflets are relatively flexible, the valve area will increase in response to the increase in the stroke volume. And if there is true severe aortic stenosis, which has a fixed valve area, so the valve area will not change with the dobutamine infusion. So if there is pseudo severe aortic stenosis, valve area will increase. The dose used for dobutamine stress echo is, we should start from 5 microgram per kg per minute in a 5 microgram incremental value every 5 minutes up to maximum of the 30 microgram per kg per minute, or until the LVOT velocity or VTI reaches the normal value, like until the LVOT velocities are between 0.8 to 1.2 meter per second, or VTI between 20 to 25 centimeter. So in case of true aortic stenosis with dobutamine stress echo, there will be increase in the peak velocity and VTI of both LVOT as well as aortic valve. So the ratio of VTI, LVOT VTI to aortic velocity VTI, it will remain constant. And the aortic valve area by continuity equation will be less than or equal to 1 centimeter square. But in case of pseudo-severe aortic stenosis, due to the dobutamine, there will be higher stroke volume. It will lead to the increase in the excursion of the aortic leaflets, and it will lead to the increase in the aortic valve area. So with the dobutamine infusion, there will be increase in the aortic valve area. There will be increase in the LVOT VTI, which is far greater than that of the aortic valve VTI. So the ratio of LVOT VTI to aortic valve VTI will increase. So if there is increase in the aortic valve area with the infusion of the dobutamine to more than 1.2 centimeter square, it is confirmatory that this patient has pseudo-severe aortic stenosis. So this image shows that first image shows this is dobutamine stress echo and severe aortic stenosis with normal function, which has high gradients, severe aortic stenosis with low gradients, and with the infusion of dobutamine. So there will be this, the ratio will remain constant. LVOT to aortic valve VTI ratio is constant, 0.2. Well, in case of the pseudo-severe aortic stenosis, the ratio increased. And see here, the ratio is now, it has increased from 0.2 to 0.3. So as we are discussing dobutamine stress echo, we must discuss contractile reserve also. So by definition, contractile reserve is increase in the stroke volume of more than 20% with dobutamine. And it is measured as 20% increase in the LVOT VTI by pulse wave Doppler. So failure of ventricle to augment with dobutamine, it predicts a poor outcome with aortic valve velocity, and the perioperative mortality will be as high as 50% if there is no contractile reserve. So response to dobutamine stress echo can be with true severe AS, AV gradient will increase, stroke volume will increase, and aortic valve area will not change with true severe AS. But if there is pseudo-severe aortic stenosis, means it is functional aortic stenosis with mild to moderate aortic stenosis, aortic valve gradient will increase, stroke volume will increase, but with that aortic valve area will also increase, and usually it increases to more than 1.2 centimeter square. And where there is no contractile reserve, there will be no change in AV gradient, stroke volume or aortic wall area with dobutamine infusion. Now paradoxical low flow severe AS. So to define paradoxical low flow severe AS, patient must have LV ejection fraction of more than 50%, and aortic wall area by continuity equation should be less than or equal to 1 centimeter square. Aortic Vmax by Bernoulli's equation should be less than or equal to 4 meter per second, and this pressure gradient should be less than 40 millimeter of mercury, and the stroke volume index should be less than 35 ml per meter square, and measure when the patient is normotensive with blood pressure, systolic blood pressure of less than 140 millimeter of mercury. Here, what happens with severe AS, there will be concentric LVH, and it will lead to smaller ventricular cavity, and this LVH will lead to the reduced LV compliance. So ultimately, this all things together will lead to reduced stroke volume, and so low stroke volume will give us paradoxical low flow severe aortic stenosis. So this is all we discussed about the echocardiographic quantification of aortic stenosis. Thank you very much all.